Good evening, everybody. I want to welcome you all and thank you for coming. I know this is an issue which is important to you, and I'm glad that at least some of us are not so weary from the debate and discussion and everything that's gone on over this past year that you still want to talk and hear about it. In preparing for tonight's program, as I looked over much of what had been written in the lead up to passage of the healthcare bill, there were all kinds of predictions as to what kind of bill would be passed, if indeed any bill would be passed, and what process the Congress would take in order to pass it. Since then, there have been as many predictions about the short and long-term results of this legislation, both politically for the two major parties and substantively for what we may call, for lack of a better term, the American system of healthcare. As for the discussion of political consequences, we will leave that to other speakers and another night. The focus tonight will be on what this legislation will mean to us as individuals, to our country as a whole, and to the way we maintain our health and treat our illnesses. As in the lead-up, predictions here have been all over the map as well. Ultimately, some will turn out to be prescient and some remarkably wrong. I remember well as a medical student when Congress was debating Medicare and Medicaid legislation in the mid-60s. The talk in the doctors' lounges and locker rooms at the hospitals was that these were the devil's own instruments. They would destroy medical practice as we knew it and institute socialized medicine in this country. Despite those initial misgivings, however, few can deny that that legislation proved to be a goose which laid golden eggs for a generation of physicians and hospitals. Despite the difficulty with predictions, they are the best way, perhaps the only way, we have to plan for a future consistent with our values and goals. We have assembled here tonight a panel of experts who have a wealth of experience in assessing likely outcomes and suggesting ways to promote those we value and mitigate those we find adverse. Their biographies are so extensive that rather than take time to read them, we have printed them out. You have them there. I will introduce them briefly and let their words speak for themselves. To my far left is Rabbi Danny Nevins, Dean of the Rabbinical School here. He's a member of the Committee on Jewish Law and Standards of the Rabbinical Assembly, where he chairs the Subcommittee on Disabilities in Jewish Law and is a member of the Subcommittee on Bioethics. To his right is Paul Howard, Senior Fellow and Director of the Manhattan Institute's Center for Medical Progress and Managing Editor of Medical Progress Today. To his right is Nancy Dubler. Ms. Dubler is a senior associate at the Montefiore-Einstein Center for Bioethics and professor emerita of bioethics at the Albert Einstein College of Medicine. She is a consultant for ethics for the New York City Health and Hospitals Corporation and consults with federal agencies, national working groups, and bioethics centers. To her right is George McGurn, an internationally recognized professor of management and an innovative entrepreneur in transitional economies. Currently, he is president and CEO of the American Hospital in Tbilisi, Georgia. When operational in October of 2011, that hospital will be the first internationally certified hospital in the South Caucasus. To his right is David Kraemer, the Joseph and Dora Abbell Librarian and a professor of Talmud and Rabbinics at the Jewish Theological Seminary. His particular interest is in a literary analysis of rabbinic culture, rabbinic ritual, and the social and religious history of the Jews of late antiquity. To his right is Dalia Remler, She is Associate Professor at the School of Public Affairs of Baruch College and the Department of Economics Graduate Center, both of the City University of New York. She is also a Faculty Research Fellow at the National Bureau of Economic Research and has published widely in a variety of areas of healthcare policy. To her right is Alan Sloan. Mr. Sloan is Senior Editor-at-Large of Fortune magazine, a 7-time winner of the prestigious Gerald Loeb Award, business journalism's highest honor, and has a distinguished 40-year career in business journalism. Finally, to his right is Alan Mittleman. Professor Mittleman is a professor here of modern Jewish thought and director of the Louis Finkelstein Institute. He has been a director of a major research project initiated by the Pew Charitable Trust entitled Jews and the American Public Square. I should thank at this time as well the Jewish Theological Seminary, the Finkelstein Institute, and the Revson Institute for helping to sponsor this evening. It is a measure of the compromise that went into the passage of the healthcare reform legislation that no one is completely happy with it. Though there are significant disagreements as to exactly which provisions are most salutary and which are most problematic. We may well ask why this process has been so difficult and so elusive when almost everyone seems to agree that the healthcare system in the United States was in need of reform. Perhaps it is in part that sometimes what is best for society is not necessarily best for the individual, and vice versa, leading to what may be referred to as the Hillel conundrum. The sage Hillel, you remember, asked, Im ein ani li mili, if I will not be for myself, who will be for me? Uchshani la'atzmi ma'ani, but if I am only for myself, then what am I? Finally, it seems pretty clear that our national debate has shed way more heat than light on this important issue. We hope to reverse that ratio tonight. So let me begin with what should be, and perhaps is, one of the least controversial issues of the healthcare legislation that was just passed. And that is that when this legislation is fully implemented, and it is predicted that approximately 95% of the people in this country will be covered by some kind of health insurance, the majority of those who are not covered will be undocumented immigrants. In fact, this seemed so uncontroversial that during the President's State of the Union address, you remember when Representative Wilson from South Carolina shouted out, "You lie," when the President said that undocumented immigrants would not be covered, there had never been any suggestion by anybody that I can remember that they should be covered. So let me tell you a story. When I was an intern working at the Boston Veterans Hospital, an elderly man came to the emergency room with pneumonia, saying that he was a veteran of the Spanish-American War. Although he didn't have any documentation with him, he looked old enough to be a veteran of the Spanish-American War. So we admitted him to the hospital to take care of his pneumonia. And you should know that at that time, Spanish-American War veterans had priority for admission to all VA hospitals. Well, 3 days later, his papers came through. And sure enough, he was a veteran of the Spanish-American War, except he had fought with the Spanish. So here's the question. Unless we expect 911 operators to ask anybody who calls them whether they are documented and have coverage, unless we expect EMTs coming to an automobile accident to ask anybody if they're documented and have coverage, these undocumented immigrants are going to get taken care of, and are going to get taken care of in a way that we all know is the most expensive and inefficient way to take care of them. So this rather uncontroversial provision of the law, were they not included because it was politically untenable to include them, or is there some other reason that they shouldn't be included? And let me ask Mr. Sloan to begin this discussion.
How am I supposed to know that? I mean, I have enough trouble in Washington when I talk to people where we know each other and I know the subject matter. Here, I have no idea why they did it, though my bet would be, since you ask, that...
Can you all hear him, by the way?
My bet would be that these people are going to get covered in exactly the way you suggested, and that way the Democrats who ran this through everybody could get the benefit of having the people covered while saying they weren't covered, and they were getting a twofer, which to me is like much of this legislation where they're trying to get everything for everybody.
Dr. Remler, should we have included them? Or if we didn't, why didn't we?
I think the answer to why we didn't is largely political, but it's related to the larger issue of who is included in us. If we have an obligation to take some level of care of everyone and we want something to be universal, who's included in the us. I would note that when people contrast the U.S. with Europe, the U.S. is a society which is willing to get a lot of people in, and then we don't promise to take wonderful care of you. In Europe, they're much more reluctant to let people in, and then they take very good care of people with the us. And so I think there's some sense that if we're going to start expanding who we take care of, we want to draw the line there.
Yes.
I think this is a excellent example of something that underlies is an underlying theme of the kind of lack of dialogue, to put it mildly, that we all witnessed over the last 14 months, in which the perfect is really the enemy of the good here. Now, on this larger number that are being covered for the first time, we have shrunk enormously the number of people that are just like the undocumented immigrants that are going to do it anyway, as Alan suggests. But we've put them under the tent, as it were. It's not perfect. But it seems to me that by focusing on those people, and I hesitate to say who have relatively more validity in entering the system, but that does seem to be the reason why some people said it was a lie and some people said it wasn't a lie. It clearly was excluded, I think. Is that correct, Dahlia?
It certainly
was omitted.
It very explicitly says that almost all of the financial benefits of added insurance, participation in the exchanges, subsidies you're going to get are restricted to U.S. citizens and legal immigrants. All of the legislation clearly says that. On the other hand, no one's proposing to change the laws that I'm sure you're all familiar with. If someone comes in unstabilized into a hospital, they have to take care of them to the point that they're stabilized. And that law, to my knowledge, has not been changed either.
So it seems to me that it's a wonderful place to start the discussion because it locates health care reform, as Dahlia noted, in the context of what kind of a society we are and what kind of a society we would like to be. So EMTALA, the Emergency Medical Labor and Transportation Act says if someone shows up at your ED and they need care, you have to provide them care. If someone is passed out on the street bleeding, I think it would be incumbent upon us as a society to try to get that person to some care and figure out why they're bleeding. And yet, American society has been very comfortable over the last 40 years in increasingly dividing people who are beneficiaries of the goods of society and people who are not. And illegal immigrants, who obviously play a critical role in the economy of the nation, are not to be beneficiaries of the goods of society. And so health care reform is one of those steps in American society that begins to focus on the undiagnosed and discussed issues that underlie where we as a society have gone and where we want to go.
I'm just going to move into Jewish text for a second and say that I think that there's a similar tension within the world of Jewish values. On the one hand, the Bible has this beautiful ideal. You should have one law for you and the stranger who lives in your midst. Mishpat echad yeh lechem v'lager gar b'tochechem. And that's beautiful. That would indicate that you can't differentiate between citizens and non-citizens, which is essentially how you might look at that. And yet, if you look at rabbinic texts, you find that they do quite a bit of differentiating between Israelites and non-Israelites, or Jews and non-Jews, in terms of the obligations of a society to rescue life, for example. It's sort of something we try to sweep under the carpet a little bit because we want to play up the moral value of an equal treatment for everyone. But I think the reality of our literature is that there has been differentiation for quite a long time. So I'm not sure that this isn't a new dilemma that we're negotiating as Americans. I think every society would like to think of itself as fair-minded and caring for all within it, and yet also has to draw some limits so that those who pay for a society and are full participants in it will have some benefits.
I think that's right. I mean, Dahlia pointed out, and I don't study really comparative healthcare systems, but one of my colleagues who does study Switzerland, she said if you're an illegal immigrant in Switzerland, everyone is covered, but if you're an illegal immigrant, they'll put you in a car and drive you to the border. They've made some decisions about their immigration system. It's an immigration question primarily, but there are trade-offs. I think that's the first question you have to recognize when you're talking about healthcare, no matter what perspective you approach it from, is that there are fundamental trade-offs that you have to make about cost and who's going to be covered. But in many ways, we are a relatively generous society. We do spend more on our elderly than other OECD countries, as I understand. Perhaps Dahlia could correct me. We spend quite a bit on the poor through our Medicaid program. Some people might say it's not quite generous enough, but we still spend, I think, upwards of $400 billion in that neighborhood on the poor. Where we have fallen down is actually in between those spaces. We do actually have federally qualified health clinics. We do have EMTALA, so those are the last of the safety nets for catching people who are illegal immigrants who don't cover one of those other programs. But in the middle, for people who work but make too much money to qualify for Medicaid, but don't get insurance through their employers, we have a problem. And that was one of the things I think we could all agree about. I think one of the, it was a very partisan, ugly discussion oftentimes, but when the president and the Republicans met at the Blair House, it was, I think, a fascinating discussion for all the things that they did agree about in terms of what the problems were in the system as far as costs or coverage and things that they did agree about. So that's another interesting place to start.
Okay. Bobby in the back is going to be going up and down collecting your questions, so if you have some, send them forward. So picking up on what Paul just said, I want to move from this relatively uncontroversial issue to perhaps what has been one of the most contentious issues in the debate, and that is the idea of the individual mandate. I mean, there was one thing about this particular group who could not get into the system even if they wished to, but a lot of the argument that has been raised about the individual mandate, the requirement to buy health insurance, is talking about a different population who may choose not to. It's interesting because it brings up this whole dichotomy of liberty and justice. What freedoms do we have? Should someone have the freedom to opt out of buying insurance without being fined or taxed, whatever you want to call it? And how this relates to all issues of responsibility. In Ellen Zane, who is CEO of Tufts Medical Center in Boston, in a letter to the entire medical center, in which she described the elements of the healthcare legislation she thought were important, it's particularly important to them, one of the things she talked about was this individual mandate. And she said, and I quote, we have learned in Massachusetts that this is a critical piece to achieving near universal health coverage. And others have written that voluntary coverage is unfair to hospitals who are prohibited from turning away the uninsured, or to the insured who are hurt as a result of cost shifting, and that unless insurance is mandatory, it is unfair to prohibit insurers from using pre-existing conditions. So here's my question. Is there any validity to the argument that buying health insurance is like buying anything, and the government shouldn't be able to force you to buy anything? Or is buying health insurance really a different horse altogether? Is it paying your way to participate fairly in the healthcare system? Because can you really opt out of the healthcare system if you get sick?
Okay. So first I'd like to make an analogy. To pay for defense, and I mean both defending the country against outsiders and police, we force everyone to pay taxes. And that's not controversial among conservatives, many of the people who are unhappy about the individual mandate. From an economist's point of view, it'd be hard to figure out how to pay for defense in any other way. If you didn't require people, they would simply free ride. The individual mandate is very similar, but it's a little more complicated. Health insurance is about taking from the healthy and giving to the sick, except that we don't know who's going to become sick. I'm healthy today, next year I might have cancer. I don't know. I can go out in a private insurance market and just buy health insurance for this coming year. I'm healthy now. I don't know what's going to happen to me in this coming year. I can buy health insurance. But supposing this year I get cancer. Next year, I want to go out and buy health insurance. I don't really want health insurance. There's no just in case. I have cancer. I don't need insurance just in case. I'm sick. I need medical care. No one, not even a not-for-profit health insurer who wants to be charitable, is going to be able to sell me to this. They'll go bankrupt if they do. The private system without things like a mandate won't supply for all of us what we want. Protection for the rest of our lives so that we can have health care and not go bankrupt. You can't really get that in a market system. I can point to lots of complicated economics papers. So the mandate is needed so that I don't hang around, not buy insurance, and then I get sick and say, oh, hey, you insurance company, sell me insurance, okay? They don't do that now. They shouldn't have to. If we want a system in which basically they can't turn away people with pre-existing conditions, we need the mandate. It's something we need the same way we need taxes to pay for defense. So yes, it is different. It's a little bit harder to explain, but it's like paying taxes for defense.
No, there's a good economic argument to be made for the mandate for lots of reasons that Dahlia just explained. And that's one of the central problems, as you pointed out. I think conservatives, at least conservatives is a monolithic term, but there are all sorts of conservatives, there are all sorts of liberals. It's dangerous to use the umbrella terms. But I think the uncomfortableness is just with the idea that you're going to be asked to purchase a product and your choice in that product is going to be very minimal. I'm a little uncomfortable with the mandate, but I recognize that there's some pretty powerful logic there. I'd also be open to other things. I mean, we can find ways of saying, like, well, if you want to be, the real problem here is that we've told people that both you can be uninsured and you can show up at the hospital and we will cover you to some extent. Now, we can also say to people, if you choose to be uninsured, you can check off some box and you will suffer some consequence for that. There'll be a real penalty. Now, that may not work, but one of the things I think we're having is some experimentation right now. We are seeing, how that mandate's working out in Massachusetts. I think that experiment's ongoing. The insurers have complained there that it's actually a weak mandate and that people are buying coverage when they need health care and then dropping it right afterwards. And what that means is, and Dahlia's right, the penalty is kind of critical here. So you could get a situation in the health reform where we've said to people, you have to buy health insurance or we'll fine you $600 or $700. But it could cost you several $1,000s per year of buying health insurance every year. So you might take a rational choice and say, you know what, I'm going to pay the penalty and go without insurance until I'm really sick, and then I'm going to jump into the system, and then you get that exact same scenario you talked about earlier. That is something I think some economists have worried about that's being played out, and I think some conservatives would say, well, gee, we could talk about how to encourage more choice and competition, but also we're going to see how that plays out.
Yes, George.
I had more to say.
The mandate is a fascinating thing to trace through history, and as a citizen of the Commonwealth of Massachusetts, I have a certain amount of experience here. And indeed, as Paul suggested, in Massachusetts, there was a very definite mandate. It was too low, not surprisingly. It's risen once and is about to rise again to deal with those issues. And all of this healthcare reform is just loaded, I happen to like it, with all kinds of experiments. And what we don't have is all kinds of data in order to make really good informed decisions. But Massachusetts is one area that gives a very good example. It's also, I mentioned earlier, one of the great disappointments, and I've been out of the country actually kind of watching this, but one of the great disappointments I've had is this kind of lack of serious dialogue that went on, because, and Nancy, correct me if I'm wrong here, but the healthcare mandate was a Republican idea in the 90s. And suddenly, once it was adopted, it was rejected like everything else. So that's confused me. Also, since a well-known ex-governor of Massachusetts gave me the mandate.
I guess we have to say one word about the quality of discourse over the last 14 months, which has been not uplifting. And the only thing I would say, I'm in the middle of one of the Oxford history volumes called What Hath God Wrought, which is a wonderful volume that covers the sacking of Washington in 1812 up to the Civil War, and the quality of discourse was not much better. American government was structured to encourage dissent and to have tugs and pulls among its parties. It's been particularly unpleasant, but it isn't anything new.
Let me just read you a statement that was written a couple of weeks ago in the New England Journal of Medicine by Timothy Yost and have you react to it. One of the problems he feels exists with the individual mandate is that it's largely unenforceable, especially where states are passing laws or encouraging people to violate the federal law, sort of like the state marijuana laws that the federal government has just chosen not to prosecute people under who are using medical marijuana. He says, if individuals successfully resist accepting responsibility for being insured, there will be no way of expanding affordable coverage in a system that depends on private insurers. If government funding of health care must therefore be increased, it may not be the result the resistors want.
Tim has had a wonderful blog for law professors in which I don't participate, but I do read on the development of the healthcare reform. And I think what has become clear to many is that if the states encourage this dissent from participation, the states will first feel in their systems the bite of underfunding. And therefore, it's a perilous game if they choose to play that. Now, it's not clear which attorneys general will, in fact, come in on the suit challenging the constitutionality of the law, but there are very serious issues that will clearly come to the Supreme Court, probably not in the next term, but the term thereafter, on enforceability.
Dahlia.
I think the state challenges will go away, both for financial pressure and because I'm not a lawyer, but I think the federal government will hold sway. But I think there is an issue going back to the size of the penalties. There are people who are going to say, I don't want to buy this. And I think that we probably will have to raise the penalties. I think that this crisis will be with us forever. Every wealthy country in the world has a healthcare crisis. We will have one forever. This is the first. There are all sorts of things. We don't know how they'll play out. Even with the mandate, people can still game their insurance. I can say, I'm healthy now, I'm going to get the cheapest possible plan. I get sick, I'm going to go out and buy the deluxe. The deluxe plan is going to have all the sicker people. It'll be more expensive. So there are a lot of potential problems we can still have. Many of them we will have, including people deciding they don't want to buy in until they're sick. It's a first stage. We can't figure out how everything is going to play out.
There have been several questions passed up here on the general theme that our country has the best medical system in the world, and that most everybody is happy with it, and in most other countries, and several of the writers mentioned England and Canada specifically, most everybody is unhappy with it. And they ask, with these changes, do we expect that the American healthcare system will deteriorate? And I would add to that that one of the primary features of the American healthcare system has been its effort at innovation, new technology, new medications, new procedures. And will that, it's a little bit separate from healthcare, but it's a piece of it. And will that deteriorate? And I want to start with Paul, because I know this is something you feel strongly about. You've written about it. So why don't you start?
It is
with
near and dear to my heart. I think one of the really brilliant political things, I'll just say a minute about this, was that President Obama really, I think, took a very smart tact on this, and to say, really, if you have employer-provided health insurance right now, not much is going to change. Many of the changes in the bill, maybe the most important reforms in the bill, or many of the things you might not like, don't kick in for several years yet. So I agree with Talia. We really don't know how things are going to turn out. I think it's extraordinarily dangerous to try and compare healthcare systems in terms of things like infant mortality, like how do pregnant teenagers in the U.S. compare to pregnant teenagers in France? Those kinds of problems. How do we fare on obesity? It's very hard to compare us and other countries that are very different ethnically, like Japan, for instance. Very hard. But one thing that is clear, at least I think, from the statistics that I've seen in the place like Lancet Oncology and other places, the U.S. tends to do really well on high-tech care, particularly for very serious chronic diseases like cancer. If you look at any of the metrics in terms of patents issued, profits for the pharmaceutical industry, number of biotech startups, the U.S. is well ahead of the curve on our wealthy competitors because we have, and this is why we spend more, there's just no doubt about it, we offer very generous health care with a system that's open-ended in terms of how much your employer is going to spend on you or how much the government's going to spend through Medicare, and that does translate into an awful lot of innovation. I think as government's share in the U.S. of healthcare goes up, it is inevitably going to have to ask questions. During dinner, this came up, something about rationing and how you go about apportioning healthcare. The assumptions built into the bill are going to play out, and we'll see how they play out. But I think that's my primary concern, is that innovation will eventually be hurt as the government share of healthcare rises. After all, most of the spending we do on healthcare is on the sick. It's not on the healthy. And those are the people who I think are going to find, eventually, particularly the elderly, are going to find their choices constrained. Now, you can argue whether or not that has to happen. I think that's a fair question, but that's my concern.
So I would point out, it's true that definitely true that the U.S. does well in high-tech care, and that the U.S. has been a major innovator, and it is absolutely true that those are related to why we spend more. It's not true that the U.S. healthcare is so much better, and that people in other countries don't like their healthcare. That's not true. There are a lot of surveys. But what I would say, responding to Paul, is that any cost containment, whether it's through public insurance or private insurance, is going to be felt on those fronts of the very high-tech care. And, hey, we don't know if this works yet. We're still trying to figure it out. Let's try it. Those things do lead to more innovation. If you have more cost containment, you get less of them. But private sector cost containment, just like public sector cost containment, has that effect. So it's not, I think, primarily about the government. And we spend an awful lot of money. We spend more than anyone else does, and there's a lot of indication that a lot of it is not useful. Is some of that us trying things as we struggle to find out what's useful? Yes, some of it is. And so may some of that be lost? Yes. But again, the pressure for cost containment comes from everyone. It comes from our personal pocketbooks. It comes from small businesses. It comes from large businesses. And any kind of cost containment has that threat.
And I would ask also, and I'll get to you, is it possible that we put too much faith in the whole notion of innovation? It was about a month ago that the doctor who invented the PSA test, prostate-specific antigen, said that he regrets the way it has been used. And how many men have had surgery or other treatment for prostate cancer who didn't need it because we had this technology that everybody wanted to take advantage of, and it took a lot of people going through these procedures and treatments to discover that it wasn't very useful in the long run.
So were my husband here, he would accuse me of having a Marxist moment. And that Marxist moment amounts to, we might actually lose a little innovation. And that's okay, because we now ration by race and class. We now cost contain where people stand in the economic spectrum. And we have a system which, from my perspective, isn't justified ethically as a fair and just system. So it's all right if we gain something. And I do think, for example, that where we stand on infant mortality may not be the end-all and be-all figure, but it's definitely relevant to how we as a society think about healthcare, which has been acute technology, which has not encompassed public health, which has not done well at chronic disease, which has not been able to keep the elderly out of the hospital. So there's a basic reorientation toward primary care and family medicine and keeping people well and not dealing with them when they're healthy. So I think it would be all right if we lost a little innovation and gained some other parameters.
One person asked, is it too much of a simplification to reduce the issue to who we want to do the rationing, the government or private insurers?
I have to come to the Atul Gawanda article, because for those of you who didn't read it, it was in the New Yorker about a year ago, and it compared the cost of health care in Medicare in two communities. One community was on the border in Texas, where doctors had a for-profit interest in what they sent their patients on to, and guess what? There were very high medical costs per capita. And then it compared that with a fee-for-service, with a salaried physician system, which had better outcomes and much lower cost. So it's not just tinkering with WHO rations. This is a system that needs basic intervention to be certain that everyone comes in so that the burden is shared equally, and quite frankly, to take certain practices which have grown up in the last 30 or 40 years and which are unjust and unfair and greedy and need to be stopped.
Like which ones?
Like doctors owning facilities, which permits them to send their patients there, and they get profit from when their patients go to those facilities. And so there's more heart testing, heart intervention, heart surgery done, and much greater incomes for the physicians who participate in those systems.
Right. Are you a fan of fee-for-service at all, or should all doctors, all medical professionals be salaried? And if so, who should set the salaries?
I think I'll take the first and the third and the fifth.
Alan, you want to?
No, again, my specialty is not medicine. My specialty is taking big numbers and trying to reduce them to a language approaching English and grasping one or two points that I can understand. And I have a doctor in the family, but she's on salary. She's an ER doctor, and that makes a lot of sense to me for people to be on salary. The thing that I have trouble figuring out is who should make what salary and how it works. And when I look at what we have here, which is going to be a tremendous increase in the amount of medical care, in the country, which in many ways will be good, you are not going to see anything like a proportionate number of increase in doctors because they're cutting doctors' salaries, or at least letting them grow more slowly than they'd otherwise grow. So I think in the end, what you have is a lot of people who have gotten used to doctors who are going to end up at clinics, who are going to end up with nurse practitioners, which is not necessarily a bad thing, but we ought to at least be honest about it and say this is what's going to happen. And being old and having been extremely lucky myself in the healthcare system, very fortunate, I think what I'm going to try to do if I live long enough is to figure out how I can stay with my doctors who go to concierge care, because I think you're going to end up with that divide in this society. Instead of the divide you're talking about, which is a bad divide, you're going to have a different one. And it's going to be people who have concierge service and everybody else. I mean, you don't think that's wrong? Do you disagree that might happen? I'm just curious. Oh, okay.
I just wanted to add a Jewish concept into the mix. We are here at JTS.
And I'm going to push my other colleagues to do so as well.
So the Bible has this great line, don't put a stumbling block before the blind. Lifnei iver lo titein michshol. And the rabbis expanded that, and they said there are lots of people who have an incentive to do something which is destructive, and others have a responsibility to protect them from their own inclination. And it seems to me that this is a case that's a bit like that. When there's a profit motive for a physician to order unnecessary tests at a clinic that they own or at a pharmacy that they own, more medications, then it's actually taking away the benefit of the patient, and it's placing a motive in front of the physician, which is not for the patient's benefit. So I wouldn't be too literal in the application of this, but it's an important moral principle that we need to be careful about what types of incentives we place before people and what types of impact they have on the broader society.
Let me just stay with you a minute, because I think it's a very good point. And I would ask you how, if at all, do you think it applies to advertising by physicians, by drug companies, by hospitals, by specialists?
Right. So obviously, you can defend advertising because people need to know where the products are. I was driving yesterday. I still drive every few months, and I was in New Jersey, and I saw a sign for a hospital, and good to know that even though Dad's hospital shut down, there's still a sign for it. But it's good to know where you can find the services that you need. And so I think the society does have a benefit in that. You wouldn't want to have a blackout, but when people are advertising on television for medications which no one should be self-prescribing, that's actually a harm to the public health. So I think we do have to worry and regulate advertising to make sure that it's actually consonant with the public good.
Paul, and then David.
Just a quick announcement about the physician-owned hospitals. There was a great series in, I think it was Forbes magazine last year, that talked about hospitals and their not-for-profit status versus for-profit status. A lot of hospitals that were not-for-profit, more were in the black than for-profit hospitals. The reason that some of these hospitals do well is because of the Medicare fee-for-service system that's set by the government. So you've got the government that pays for certain kinds of service, and what the hospitals then do is say, hey, we can make more money doing that service, and this is for-profit and not-for-profit hospitals, and game the system. Now, in a typical market economy, you face prices for all kinds of things, and you decide whether or not you want it. But when the person who shows up at the hospital doesn't know what the price being paid is or the quality being paid, there are all sorts of distortions and cross-subsidies that happen. But the data that everybody talks about, the president talks about, and I think it's fair to remember this, it's about Medicare data and decisions about Medicare hospital data from hospital to hospital. Even in New York, between hospital to hospital, prices are very, very different, or rather spending is very, very different on patients that, as far as Dartmouth could see, were basically very similar.
I just want to see if I can get David or Alan to say anything.
I just want to respond. I mean, there's a lot of things I could say, but the area variations, which basically mean that in one place they have a certain procedure far more often than another, and there's an industry in this. Paul alluded to the Dartmouth group, who are the inventors of this, and basically in tons of countries, in tons of parts of the United States, it's definitely not restricted to Medicare. They do a lot of their work on Medicare because the data is the easiest to get. But there's a historical one showing there were 8-fold differences in tonsillectomy rates between adjacent counties in Vermont. This is a decades-old study. We do a lot of things in Medicare, in medical care, not just in Medicare. So I do want to say it's not just related to the financial incentives. Financial incentives matter, but there's a lot of other variation, which as far as anyone can tell is waste, because they're doing a lot more tonsillectomies or whatever in one place, and as far as anyone can tell, there's no medical reason and there's no better outcome, so it's kind of a waste. So there's a lot of stuff, and it's not just in Medicare. I also want to respond to what Paul said about this is a very messed up market. It is, but that's because it has insurance. If I have insurance, I'm not paying. So I'm the person getting the service, but my insurance company is paying. And I was also the person who bought insurance along with a lot of other healthy people, so I'm spending other people's money. And I want to point out again, that is true in private insurance and in public insurance both. A lot of the ways we're very messed up, and a lot of the reasons we need different kinds of cost containment are because we have insurance. And unless you want to give up insurance, we will have that problem. And we will need to find cost containment methods. And I don't know if you want to segue into this, but one of the things about all the cost containment methods, they all have problems. And when people complain about their problems, they're right. But that doesn't mean we're better off having no cost containment.
No, I agree. I completely agree that the problem is third-party payment. And that just means you're playing with someone else's money. And I would have a preference for more bottom-up, market-driven ways. Other people might say, well, cost containment from the top down is better, but that's fundamentally right. That's the problem you're dealing with is when you show up there, whether it's through private insurance or public insurance, that the use is not constrained by the price facing the person.
But there's a limit to how much out-of-pocket payment we want. Most of the money is spent by the really expensive people. Like roughly 5% of the people are responsible for 50% of the money. You can only have so much out-of-pocket payment if you're talking about a $50,000, $100,000 kind of episode. At that point, you need insurance.
There was an article in the Atlantic Monthly last summer in which the writer, I've forgotten his name at the moment, David Goldhill, pointed out that because we expect to cover all of our medical expenses, except deductibles and all that, with our health insurance, it's like expecting our automobile insurance to pay for our car washes and our oil changes and our homeowner's insurance to pay for a new paint job, and that he's suggesting that a lot of the less expensive, more preventive kind of care should not come through an insurance. Insurance should be for the kind of things that Dahlia talked about.
The problem with that is the studies show that people will not go to preventive care if they have to pay out of pocket. And so the system is penny wise and pound foolish, because if you structure the interventions outside of insurance, people won't do it, and they will become more ill. They won't have their silent hypertension tested for, and they'll end up on kidney dialysis. So it just doesn't work. It's a nice idea, but it doesn't work.
Is that because, I'm going to push you a little bit, is that because of the way the system has developed, say, since the 50s and beyond? Because, I remember when I was little, long time ago, that was not the case. You had your family doctor,
That's right.
He came to your house, you went to his office, you got your blood pressure tested, and you paid him the $5 or whatever it was.
But it was $5.
Right.
So let's remember that all economic spending is relative, to take a line that Dahlia might offer. So when we got insurance for prescription drugs in Medicare, and there was that really quite disgusting hole in the donut, most of the congressmen thought that wasn't a lot of money, $2,800. But indeed, for people living on $10,000 of Social Security, and that being their only income, it was quite a lot of money. So the issue of how much you pay for what and what resources you bring to that payment, and the general escalation of what medical care has become, make all of that, I think, not a useful discussion.
The donut was part of a fiscal fantasy in Washington, where whoever it is whose idea this was, I guess, the Republicans which I'm ashamed to say include me, though for how long I don't know, they wanted to show a certain fiscal result. So they just threw in this donut hole, and I guess the Democrats were so happy to get any sort of insurance that they took it. And the Republicans claimed it would cost only a certain ridiculous amount by gaming the system. And in the end, you had the donut hole, which is now going away, or largely going away, as it should, because it was crazy. It was just crazy.
Okay. I'd like to change the subject for a minute because I know Nancy has an engagement that she has to leave, and I want to get her input as well as all of yours on this issue. David Leonhardt wrote an article a week or two ago, in which he said that this bill was the federal government's biggest attack on economic inequality since the inequality began rising more than 3 decades ago, that it was the centerpiece of President Obama's deliberate effort to end what historians have called, and I'm quoting, the age of Reagan, to smooth out one of the roughest edges in American society, in large measure by taxing the rich. He goes on to say, in effect, healthy families will be picking up most of the bill, and their insurance will be somewhat more expensive than it otherwise would have been. And he said, and finally, I'll just quote this one sentence and get you to respond. He says, the ways in which this bill attacks the inequality of the Reagan era, whether you love them or hate them, will probably be around for a long time.
Be accompanied by others, which would roll back what I think have been distortions of fairness and equity in American society. And I think it's fair that rich people should pay more. I think it's fair that wealthier Medicare recipients should pay more. I think people who have more money should pay more. It will annoy me when I pay more, but I think it's fair and just that I pay more. And so I thought that was a wonderful column that he wrote. And I was proud that this bill began to change what I think is the great stain on American society. Another Marxist moment.
Speaking about Marxist moments, I've been, you even begged me to speak up a moment, a few moments ago, and I've been sitting here wondering why it is that I have so little to say. Which is quite unlike me, as you know, right? And it's not because I don't personally have something to say, but because I'm here not to represent my own personal opinion as a layperson, but presumably I'm here to say something from the perspective of tradition. So the question for me arises, why is it that the conversation as it's been conducted for the most part to this point, and the tradition that I want to represent, seem to have so little to say to one another. And it occurs to me that when I open up the sources from wherever I might find them in the vast history of Jewish discussions of these matters, of healing, of healthcare, and the like, economics is not a factor. Right? Now, this isn't because doctors didn't make money when they served as doctors in the societies which are discussed either in rabbinic literature or in medieval literature or beyond. It's not because there weren't economic incentives or motivations. It has to be because in the discussion of obligations pertaining to health care, to saving lives, which is the way it's often discussed, they didn't want the economic factor to be the driving factor for the discussion. And that's why I've actually had very little to say, because that's been a central part of this. In saying this, I want to insist that in order to broaden the discussion, it seems to me important to ask a question that goes beyond the economic incentive or motivation. For example, as all of us were following the discussions over the course of the last 14 months was the figure that you used. I, too, was interested, like everybody else, in the questions of what the consequences of the absence of insurance, for many people involves. And so I did a little bit of research. And someone please correct me because I'm obviously not an expert in this, but as far as I was able to find in my own research online, responsible studies suggest that somewhere between 25 and 45,000 lives a year are lost due to the absence of insurance coverage. Now,
Those are shaky numbers, Dahlia?
Yeah,
well, I'd like to.
I would say they were. Basically, it's very hard to do those things because people who are uninsured differ from people who are insured in many respects. They're usually poorer, amongst other things, and it's very hard to correct for
Maybe
those
you
factors.
should give her.
I understand.
It's hard. I think there's no question that to not have insurance has some impact for some people on their health. I think that much you can say, as well as the fact that it makes people, it has some financial consequences for working poor people without any question, and it also is an immensely stressful thing and takes you out of society. But I think that a lot of the health effects are heavily disputed, and I would dispute them.
Okay, well, I just want to, I don't want to discuss the economics, as I said, because I don't want that to be the motivating factor. This comes from a particular study which made maximal claims, and then I followed up on the critiques, and the critiques brought it down. Let it be 5,000, let it be 10,000, let it be whatever it is, because the question that this suggests is, what are our obligations as a society? And here I'll speak from the very limited perspective of, a Jewishly thinking person in the society that I would like to create. What are our obligations to create a system, whatever its motivations might be, that is devoted to healing and to the saving of life at a maximal level? And now back to economics, contrary to what I said a moment ago, one thing I know well from every Jewish source, from the beginning to the most recent, is that not only, the question you asked at the beginning was really about a redistribution of wealth. There is no doubt that Judaism, from its foundations, has been in favor of the redistribution of wealth toward what it considers to be justice, which in Jewish systems includes the saving of lives. And this is the reason why when we speak in Jewish settings, we don't use the term caritas. We don't use the term charity. Charity may be about the goodness of the heart. The way we describe this is that tzedakah. Tzedakah is justice, and it's about the addressing of fundamental inequities in the distribution of wealth, which the Torah calls upon us to redistribute in regular cycles so that the inequities are rebalanced in some regular cycles.
Alan, and then George.
My friend and colleague David has just suggested that there's an incommensurability between the discussion of economists and policy experts and the discussion of those who try to represent the moral sources of the Jewish tradition. True. That's why I think, except for Danny, we're pretty silent here. But there's another incommensurability as well, and that is, I would say, between the political culture that comes with the Jewish tradition, which is one of a high sense of communal solidarity, a high sense of being responsible for one another, of being willing to be taxed through tzedakah in the classic Jewish polity for public goods, such as the provision of health care within traditional Jewish communities. Between that kind of political culture and the libertarian political culture of the United States of America, historically. Len before had kind of shaped this as a clash between the values of liberty and justice. I'm not sure I'd say justice. I'd say liberty and egalitarianism, or liberty and solidarity. I think it's very difficult for Jews in particular to appreciate a political culture that says America is primarily about liberty, a mandate to purchase health care, whatever its economic benefits would be, is paternalistic. It's an infringement of liberty. That fear that we're becoming a less free nation, I think hyperbolic as it is, nevertheless has a genuine value behind it. And it's an authentic American tradition, which I think in some ways Jews are constitutionally, with a small c, challenged to appreciate.
Let me ask George and then Danny.
I regret that Nancy had another engagement and had to leave, but without having a Marxist moment, I would like to follow up on what she said and have kind of a Pareto optimum moment. David said something that I think was a really insightful response to your question about redistribution of income when you said, if I understood properly, inequities are balanced in regular cycles. And I do think that de facto, some would say by explicit design, whatever, this healthcare reform effort is a major recurrence of a regular cycle of balancing. And I would, agree. I believe David Leonhardt, is the New York Times journalist who wrote that. The Reagan cycle was another cycle, and kind of accelerated, I would argue, with the second Bush tax cuts. That although there are tax increases implicit in this, for example, someone making $1 million a year, most calculations say that on average that person would pay about $47,000 a year more, and to subsidize the least well-off in our society, in effect. No one under $250,000 would have any increase, and someone making $250,000 would be pretty minimal. But it really is one of these regular cycles, and I think a very, very significant one. And it is tilting in a new direction now, and maybe in November, or maybe in many Novembers from now, maybe 30 years, it'll tilt again in other directions in a regular cycle.
I would agree with that. I want to focus on the previous comment, but in Judaism also there were different lengths of cycles. There was, within the 7 years and then within the larger 50 years. So some corrections were minor and some were major. But I want to build on what Alan was saying a moment ago, because I think communal solidarity is actually the key to the Jewish understanding of social ethics, and it also functioned as a check on waste. Because here in our society, if I go and spend on a lot of medical care that I don't really need, no one knows. My neighbors don't know what I'm spending and what it's costing them. In fact, I might not even know how much it's going to cost. But in pre-modern societies where people knew each other and what people were taking from the public pot, there was a little bit of a social pressure on people not to take more than they needed. So we didn't have medical insurance in antiquity, but we did have some sort of a food scarcity insurance in the form of what was called the tamchui, where people were supposed to pay into sort of a communal food pantry. And if somebody tried to take from the food pantry who didn't need it, there would be some sort of social opprobrium. And the rabbis even developed statements that somebody who takes money from the public without needing it, will eventually need it. In other words, it was like a threat. And so it seems to me that that's impossible to really have in a big industrial society like America. But there could be some things that we did in our economy that would sort of educate the public about the larger implications of their own decisions. I remember one case in our family when my mother, of blessed memory, had cancer. We found out quite by accident that one of the therapies that she needed was an infusion. The pharmacy bill died, you'll correct me, was $27,000 for a 2-hour infusion. And we found out quite by accident about that. But I think if patients knew that this treatment that the doctor says might help, but it might not help, and it costs, by the way, $27,000, it could be that some patients would actually say, I don't think I need that. I don't want to think of myself as somebody who takes so much for so little benefit. And so if there's a way to reform our own system to reflect some of the mores of a smaller communal society, maybe that would be part of our solution.
Actually, I think the person who injected some Marxism into the Medicare program was President Bush, who I think was the first one to start means testing for Medicare Part D for wealthier seniors who are paying a little bit more for coverage. But I think that's a very interesting question. The point at which you redistribute something, it always seems perhaps attractive to say, okay, we've reached the point at which we have a good, and now we can extend that good. If I think of iron lungs for polio back in before the advent of the polio vaccine, we'll say, well, okay, this is the state-of-the-art technology. This is the best we've got. We're going to find some way of giving this out to everyone who's got polio. But then a vaccine comes along and makes that obsolete. That innovation does move along, and that for people who are facing diseases like Alzheimer's that are very expensive, that require extraordinary amounts of care, for which we don't have good answers today, I think that some of that little innovation we'd want to keep pushing for. And then last quick comment, I think means testing is a terrific idea. I think a lot of economists, and not to confuse the two, but a lot of conservatives too say, well, that's actually a good idea. Instead of trying to provide everything to everyone, why don't we think about getting the right safety net coverage and asking people who have more to pay more or to buy private coverage, and to try and balance the costs. I think as far as costs go, from what I can see on the legislation that passed, there are a lot of assumptions that make it, for me, a fantasy in terms of its ability to reduce costs. Lots of little experiments. The biggest piece of it, the excise tax, is probably not going to get implemented, or will be watered down for years to come. So a lot of this, I think, if you believe that with some help from transparency and price signals and other things and some safety net, that individuals will make decisions that will help drive the market in a better direction, that's what I think is ultimately going to be a better path forward than trying to do things just from the top down.
Well, I have a problem with the concept of redistribution, which, I mean, in theory it's great, but I'd love to have Paul's money redistributed to me because I need it. And one of the questions I've had, and one of the arguments I've had endlessly with people in the Treasury, is what is the definition of rich? And $250,000, to use an example, I showed my wife, but no one else has seen because it was killed, is in Manhattan, Kansas, $250,000 is the equivalent of $500,000 in Manhattan, New York. In Manhattan, New York, for a lot of people, $250,000 is not a lot of money, especially if it's it's a couple with one person staying home, a kid in school. I mean, it is not a tremendous amount of money, and the whole concept and the whole problem with the excise tax is nobody takes geography into account. I'd feel a lot better about this if you had something other than this number, but the $250,000 number is a number the Obama people picked because it's in the top 2.5% of tax returns. It's a nice round number, and 97.5% of households don't have that kind of income, and that's where that number comes from, and now it's being treated as, you should forgive the reference, sacred writ. It's like someone came down and said $250,000 makes you rich. And it's just not true. I mean, large parts of this are just not true. I'm all in favor. If you'd had the experiences I had and my family had with the healthcare system, you'd know that it was really screwed up. It's really bad. And the only members who've actually managed to do okay in it are my wife and me and our children, because we've been incredibly lucky in a variety of ways. But the idea that, well, you're rich because you have $250,000 and therefore we're just going to take your money and give it to someone somewhere else who we say isn't rich, that's how you get revolutions. That's how the Bush people now have the Democrats after them, and it's how after there's a change of regime, you're going to go right back to Bush. It's not going to be pretty.
A number of people have sent up questions.
Can I say one?
Oh, sure.
Well, I just
Yes.
want to respond. There were a lot of things I could respond to, but just about the redistribution and the fact of this is a great piece of social legislation because it's introducing redistribution, whether you like it or dislike it. A lot of this is about healthy to sick redistribution, and a lot of it is about fixing insurance markets. Yes, there's also a rich to poor redistribution, but a lot of it isn't about that. And I would respond somewhat by saying that it's not just rich people. It's people who are sort of above average to people who are not poor but are working class and lower middle class.
Okay, so I think is perhaps a little segue from there. I mentioned a number of people have sent up questions that relate to the concept of personal responsibility in the sense that people who are not sick necessarily, but have conditions that are related to lifestyle choices that are within their control, that they are not controlling, and whether it's smoking, whether it's diet, whether it's exercise, all those sorts of things. So where does that fit into the picture? Should people who make lifestyle choices that ultimately affect their health have a different requirement in terms of the healthcare system? Alan.
Just to throw out a Jewish idea, I mean, Maimonides, for example, holds that we have a very strong obligation to work for our own health, to have a healthy lifestyle, to use a current term. I don't know what that is in medieval philosophical Arabic. But I mean, going back in Jewish sources, we have the responsibility to prevent ourselves from doing dangerous things. And consequently, the community can intrude on the way we live if we're endangering ourselves or endangering others. So I think while the Jewish tradition is not libertarian, it certainly has a very refined sense of personal responsibility.
I want to respond from what I believe is also a Jewish perspective, but with a very, not a different conclusion, but a different perspective, which would complement what you just suggested, Alan. I had the good fortune, my wife asked me this question last night, so I had a chance to think about it. And it's it's a perplexing and a difficult question. What you just said is correct. There is certainly an ethic of responsibility, and Maimonides is far from isolated in indicating that we ought to take responsibility for ourselves. But the question still remains, what about those who fail to? What about those who we might blame for their failure to take that responsibility? There is, as far as I can think, no direct translation of that into traditional sources, but I think there's a very close analogy because the discussion does, meaning the Jewish tradition does discuss the question of do we owe health care to those who are wrong, to those who ought to be blamed? And it works in a very, very simple way. According to biblical theology, which was followed up in rabbinic theology, and this persisted into the Middle Ages, we become ill, at least this was certainly overwhelmingly true in biblical texts, it continued to be overwhelmingly true beyond, we become ill because we've sinned. Now, that's not the same as eating too much. It's not the same as smoking. For us, it's not. But for them, it is. Because what this means is that people have made choices of their own free will that, in the understanding of the system, has led to their illness. Rabbis from the earliest stage and beyond note this as a theological problem, asking, well, should we heal such people? And the answer, very interestingly, is this. The person who's ill ought to do tshuva. They ought to repent. In other words, they ought to change their lifestyle. But this does not diminish or eliminate in one iota the obligation of the physician to heal them. And I think that that's the principle that we would need to take from Jewish teaching, in any case, with respect to this specific question.
Danny.
The closest precedent that I've seen written about this was by Elliot Dorff. There's a principle in Jewish law of pidyon shvuim, of redeeming captives. So if somebody's taken captive, the community is responsible for their freedom. And so the presumption is if somebody was taken captive, then drop everything, sell everything, and go rescue them. But what happens if someone is a repeat captive? Let's say they are a traveler who can't help themselves from going into dangerous regions which are known to have pirates and stuff, and they sound strange, but actually they knew about this. I mean, there were people who made a living off of taking captives, and it said that actually there was sort of a triage system. First of all, when captives were taken, you would actually protect the most vulnerable captive first. If there was fear of one captive being raped, for example, you would have an obligation to protect that person more than another person who could live in captivity. But if somebody got themselves captured more than 2 or 3 times, at some point the society didn't have to rescue them anymore. It became their responsibility. It's not a perfect parallel, but it's sort of the closest thing I've seen in Jewish sources. I would say that always the presumption is that we have an obligation to heal the sick. But at some point there needs to be a dialogue between their own obligations. As the Torah says, "V'nishmartem ma'od b'nafshotechem," you should surely guard your own soul, your own life. And the last thing I'll say, just picking up on what David said, is something you never hear in the American discussion is sometimes from a Jewish point of view, it's good to be sick, right? It's good for you to be sick. And because this is something we will never, the Forge should not put it, or whatever newspaper you are, shouldn't put it in print, but it's understood that some of the trials of being ill are good for character. That doesn't mean that you should...
The problem with that, of course, is that in a time and place where it's impossible to avoid illness and difficult to heal it, you've got to provide some kind of rationale that makes you feel better about it.
Fair enough. Totally understood.
Which is why the rabbis did it, and the Greeks said that, and the Romans said that. Everyone in antiquity said that.
Right.
But we don't live in the same setting, thank God.
But even today, you will speak with patients who will say that if it doesn't kill you, that this illness can give you a new perspective on life. And I think that since we are talking about Jewish perspectives as well as general economic perspectives, we should think a little bit about the ways in which healthcare is also about our spiritual life, and how the way we heal people and the way we seek healing for ourselves should also be supportive of our own sense of the value of life.
I want to ask one final question because we're coming close to the end. We talked a little while ago about the problem in this country of overutilization of healthcare procedures and facilities. One of the questions that was raised here related to the question of medical liability reform, malpractice reform, how that fits into the picture, how much of the overutilization is the result of physicians and hospitals practicing defensive medicine?
A relatively small share. That's what the evidence shows. That's from, for example, comparing states where they have much more protection against malpractice. It's there, it's not nothing, but it's small.
Did you have?
Yeah, no, that's right. So I think it has an effect on premiums for high-risk specialties like obstetrics and neurology and other things like that. So, you can certainly frighten doctors away with medical malpractice premiums. And there is some effect on what they call defensive medicine, which is doctors ordering tests for things just in the fear that they might get sued. But is it the lion's share of spending? No.
And it's not, you to use the word excessive and unnecessary, and you hear those terms all the time, but sure, some things are clearly a waste, but a lot of it is a much tougher call. One person's, excess of medical care is another person's, valuable, necessary medical care, and it's, the cost containment problem is much harder. There's some low-lying fruit. There's stuff we do which anyone looks at it and says, this is crazy, but there's a lot of difficult questions
Was
there
that the
also.
issue with the mammograms?
I think that some of those mammograms are clear waste myself. But there's a lot of other things. I mean, there's a lot of care which, someone who has a headache and you could give them an MRI, and some, they haven't figured out why the person has a headache, and some share of the time it's going to be really valuable, and most of the time it's not. What are your standards for MRIs?
Just very, very short comment. So I guess the converse, is it, of that comment about, prevention? Actually, I think 8 out of 9 or probably 8 out of 10 insurers actually offer free or very low cost preventative services. So insurers aren't out there blindly denying people preventative care, because that saves them money in the long run if they can keep you healthy, assuming they keep you long enough, of course. But the other thing is, what about the world of optional health care? How do you like that new knee or hip, or any other change that physicians are going to be able to offer you the next 10 or 15 years that are going to keep you healthier, more active as you age, that they're part of what we have traditionally thought of as the aches and pains of aging. So there's the preventive angle, but what about the keeping you normal angle, or keeping you active? That's going to be an increasing question.
You're going to have an American hospital in 2 years, or in 1 year, in a former Soviet country. An American-style hospital in a very different healthcare system. How do you think that's going to work?
Well, we are designed to be a paradigm hospital in a system that was very badly designed, both from an infrastructure point of view, and certainly out of sync when we talk about comparative health care. We're talking about other developed countries and things like that. What we have done is...
Excuse me for interrupting 1 second. I saw that some people came in late. George is the CEO of the American Hospital in Tbilisi, Georgia.
Okay. Before we had a hospital, we had still the only English-speaking medical school in the former Soviet Union. We have a cadre of 68 Georgian doctors who, once they got their undergraduate medical degrees, came over to be certified in the United States and are now practicing in the United States. And part of the deal was they would go back home. So we are creating not just a physical environment and a technological environment, but indeed a cadre of people that are used to practicing in the American way. Now, we have in our hospital, like I've seen happen many, many times over the last 20 years in the former Soviet Union, kind of cherry-picked what's best. We have, in terms of, we are self-insured. That we have connected to our hospital facility. We are going to have salaried doctors a la Mayo or Cleveland Clinic, because everybody agrees that the current situation in Georgia or in the region, because we're really a regional hospital, is quite unacceptable. But at the same time, and we've done all kinds of marketing studies, 90% of the people love their doctor. And this is a very tricky thing for us to deal with.
Okay. We're just about in. Final comments from anybody? Thank you all. Thank you all for coming.